Okay, hello friends. In this video, we will be continuing the discussion on syphilis. In the last part one of Spirochetes, we have discussed some primary and secondary stages of syphilis. We have read everything about the strains, the Nicole strains, the Ritter strains, the Smith-Noguchi medium, rabbit testicles, Pinta. Okay, refer to that video for introduction and everything, the basic. Now, last time I told you that primary ulcers which we are having in the Hunterian chancre in the primary syphilis is painless ulcer. It is painless ulcer. It heals spontaneously within 6 weeks, and in the secondary we said that the skin rashes are present, the palms and soles are involved, condylometallata. Now today, and also we said something about the latent. Latent means no, I can't see any clinical features, but patient is infectious. That means in case of latent syphilis, that means in case of latent syphilis, that means in case of latent syphilis, there will be some fates. Either this syphilis will get cured, okay, either the syphilis will get cured, or it's not writing, yeah, either the syphilis will get cured, or this will continue in its phase continuation, or it will progress to tertiary stage. It will progress to tertiary stage. Okay. Now tertiary stage, you have involvement of two organs. In tertiary stage, you have involvement of two organs. That is heart. That is, I won't repeat the things again and again because yesterday I also saw. You can watch this video as many times you want. You have difficulty, okay? Because it makes it irritates the listener. Okay, you can play back the video and listen again if you feel what I said. Okay, so let me remain in my flow. Okay, so that I don't have to speak. I will in the end I will be revising again. Okay, so if you listen coolly and calmly, you don't need to listen it again. So third tertiary stage, you will have involvement of heart, involvement of CNS. In the CNS, if CNS is involved in the syphilis, we call it neurosyphilis. Neurosyphilis. What are the features? We can have GPI. What is GPI? General paralysis of insane. General paralysis of insane. GPI. We can have meningitis. We can have tabes dorsalis. Dorsal column involved. Tabes dorsalis. Tabes dorsalis. If heart is involved, it will destroy the vasa vasorum. What? Vasa vasorum of aorta. Vasa vasorum of aorta is destroyed, guys. The beautiful concept it is. It will destroy the vasa vasorum of vasa vasorum. Do you know vasa vasorum? This is your aorta. I think no need to make big videos on this also, isn't it? It's simple. This is aorta, and aorta has its own blood supply. That is vasa vasorum. Vasa vasorum. Aorta has its own blood supply. Everything has its own blood supply. Why not artery? Artery has its own blood supply. Vasa vasorum. So vasa vasorum will get destroyed by this bacteria. This bacteria will destroy the vasa vasorum. Once it destroys the vasa vasorum, it will lead to aortic aneurysms. It will balloon. This ballooning of the wall of the aorta will happen, and this weakness in the wall of the aorta is called aortic aneurysm. And aortic aneurysm is most common in ascending aorta because we have ascending, we have transverse, we have descending, we have abdominal, we have these types of aortas. So most common area is ascending aorta. Ascending aorta is the most common. Okay. Also in the tertiary syphilis, if you see the bone, I draw the bone with pink. This is bone. The bone will have some inflammatory things present. Inflammatory things. This is called gumma, syphilitic gumma. Syphilitic gumma. It is basically what aggregation of antigen antibody reaction. It is basically a granulomatous, for second year people, granulomatous lesion. It is a granulomatous lesion. It is a granulomatous lesion. You can also find gumma on the skin in the third degree syphilis. Gumma on the skin. Gumma on the skin also. So skin, bone, CNS, this is the most big manifestations you have to remember. And if we go into the, if I go to the ophthalmology, we have a constriction that is called Argyll-Robertson pupil. Argyll-Robertson pupil. You know what I do is I have an ophthalmoscope in my hand, okay, and I'm checking this patient with my one hand. This is me, and what I do is once I put the light on the patient, or I bring a light directly, I bring a light and I put it in the patient's eye. What will happen? The patient will not react to light. The patient's pupil will not react to light. It's called Argyll-Robertson pupil. The constriction will happen. This is the important to remember. Constriction will happen, accommodation will happen, but you won't be having reactive. Okay, fine. Now see guys, I had yesterday told you about congenital syphilis. I want to discuss something about that. Congenital syphilis. Congenital syphilis. See, congenital syphilis is basically, can anyone of you tell me which trimester this syphilis can damage the fetus? Which trimester can it get transmitted? Which trimester? Congenital syphilis, which trimester? Which trimester does it get transmitted? So there are wide variety of answers. That's where the clinical knowledge comes. It can transmit in any trimester. It can transmit in any trimester. Okay. And if when it damages, maximum damage happens in 3 to 4 months. Maximum damage happens in 3 to 4 months. What are the clinical features of congenital syphilis? Number 1, Hutchinson's teeth. Why it's not writing? Hutchinson's teeth. Hutchinson's teeth, or you also call mulberry molars. Hutchinson's teeth, they have notched teeth. I will be showing you the images. Okay, so they have notched incisors. Snuffles. Third, Charcot joints. Fourth, saddle nose, like we saw in the leprosy. 5, Olympian brow. Olympian brow. Fine. So congenital syphilis, the patient will provide, he will be showing us the Ragardis. What is Ragardis? What is Ragardis? Ragardis. Why I say it like this? Because you have to remember. Ragardis. What is Ragardis? Ragardis means scars on angle of mouth. This is your angle of the mouth. Scars on angle of the mouth. Okay, that's called linear scars on the angle of the mouth is called. If you want to write the definition, I can tell you. Okay, write the definition. Linear scars at the angle of mouth is called Ragardis. Ragardis is a facial abnormality. facial abnormality, facial abnormality. Okay. Okay, so they have Hutchinson's teeth, they have mulberry molars. Okay, what is Hutchinson teeth? Notched incisors, and molars are mulberry. Okay, and they can also proceed past with cranial nerve 8 palsy, cranial nerve 8 palsy, that is cranial nerve 8 deafness, cranial nerve 8 deafness, vestibulocochlear nerve affected, deafness leads to deafness. Okay, is it fine? Should I show you the clinical features, the photographs? Okay, let me show you the photographs, many photographs for you. Can you see the chancre on the mouth? This is the syphilis chancre on the lip. But where is the primary chancre? Primary chancre on the genitals. See the genitals? Okay, let me show it here only. Can we see the image? So this is the male penis. Okay, so this is the chancre. This is the chancre. Fine. Now I show you another image. Chancre got disappeared. Where is the chancre? Chancre got disappeared. Okay. This is again the male penis. Chancre. Okay. So this is a primary chancre. Fine. This one also done. This one also done. Let me tell you about, can you see the saddle nose? Can we see the saddle nose? Can we see the gumma? This is called gumma. These are gumma. That is the pen. So we have gumma. We have gumma. Can you see the notched incisors? See notched incisors, guys. Congenital syphilis. Congenital syphilis, notched. Can we see the notched incisors? Yeah, this is the Hutchinson's teeth. Hutchinson's teeth. Can we see the condylomata? Condylomata lata, see genital area of the female. Can we see the condylomata lata? Can we see the condylomata? So condylomata lata. What is condylomata lata? Condylomata lata means, what is the definition? Painless, smooth, wart-like white lesions. Painless. Do you know the definition, or I have to write for you? If you don't know, I will make you write. What is condylomata lata? It is painless maculopapular, exactly. Smooth, wart-like white lesion. Wart-like white lesion. Okay. This is what, this is the, let me take, this is the spiral form. This is your dark field microscopy. The field at the black is very dark and you are able to appreciate them. So dark field microscopy, you are able to appreciate this. If you are not able to visualize these things, it is difficult for you to become a doctor, really. That's why I'm helping you out to make these pictures, and so that you can directly diagnose at least. Okay. So this is your, what else? What else have we left behind? Snuffle. See the snuffle face? See this snuffle as sort of rhinitis in this baby, cute baby. Snuffles. Snuffles. Okay, this is the chancre on the finger. Can we see it is a non-venereal syphilis, non-venereal syphilis, non-venereal. Okay, everything has been taught to you. We are applicating, we are doing application. That is what medical science is. That is what studying is. Studying is application. Can we see the secondary syphilis? Yeah. Can we see the skin pigmentation? Secondary syphilis? Yes, sir. Secondary syphilis, skin pigmentation. Okay. So if I play a game with you, see which game will I play with you. Let me play a game. Where is the image? The image is gone. Yeah. So see how I play, how I label at home. See, This is how we practice. This is a venereal primary. This is congenital. This is venereal primary. This is gumma formation happening in the tertiary syphilis. This is Hutchinson's teeth, congenital syphilis. Condylometalata, secondary syphilis. Condylometalata, secondary syphilis. Pigmentation, secondary syphilis. Primary syphilis. Dark field microscopy. What else? It even didn't took 30 seconds to understand. It just means how your brain thinks. Done. Snuffles, congenital syphilis. There is nothing else to get confused. It's so easy. Okay, so we have shown you the clinical features also. Now going towards what to speak now after that? Lab diagnosis. So lab diagnosis of syphilis. Lab diagnosis. What is the lab diagnosis of syphilis? You do microscopy. Microscopy. You do microscopy. What is the microscopy you do? Yes. What is the microscopy you do? Dark field microscopy or dark ground microscopy. So what will you do? You will do silver staining and where in the early stage of disease, and also condylometalata. What is the staining used? Fontana levarditi. But what is the disadvantage of microscopy? What is the disadvantage of microscopy? Disadvantage of microscopy is it won't help me in primary syphilis. Remember this. Okay. It won't help me in. So what type of motility was it showing? Corkscrew motility. Levardity stain. Tissue section. Fontana stain. Smear. Fontana smear. Fluid or smear, whatever. Okay. Now I want to teach you serological tests. The important once you went to China or once you went to United States or once you went to any country, what happens is you checked, they did a medical checkup of you. You went to any country, they will do a medical checkup. Entry, exit, immigration check, plus health checkup, whether you contain any contagious communicable disease or not. If you contain, then they will restrict you or do that appropriate action what the laws of their country say. Now they will do some tests. How do they know that you have an infectious disease? For example, how do they know you have syphilis? Because once you contact with someone, because I told you it is a contact based also, once you contact with that lesion, they will also get the syphilis. Also, you will have sexual contact, you will transmit the syphilis. You also don't know that he or she is having syphilis. So we have some serological tests. Serological tests. So serological tests we call it STS. What? STS means serological test for syphilis. STS means serological test for syphilis. Okay, STS. What we do is basically we call it a non-specific test. It's a non-specific test. What we do is we check the antibodies. We take your blood sample and we check the antibodies in it. Now, this serological, I forgot to tell you, serological test can be specific, they can be non-specific. Specific, non-specific. Specific, non-specific. Let me talk about the non-specific test. Non-specific test, we will be using non-treponemal antigens. What is that called? VDRL. What you may have seen in your test report, VDRL. What is VDRL? Venereal Disease Research Laboratory Test. Venereal Disease Research laboratory test. Venereal disease laboratory, venereal disease research laboratory test. Okay. Or you do RPR. What is RPR? What is RPR? Rapid plasma reagent. Rapid plasma reagent. Rapid plasma reagent. Okay. Now, if you got it positive, what is the result? I say I have a patient and he has a positive VDRL and RPR test. What is the meaning of this? I am writing here. See, VDRL is positive. Let me write it here. First, your understanding. I say VDRL is positive. What does it mean? Not confirmed diagnosis. Very nice answer. So what is it? No, he is positive with syphilis. But what is the meaning of this? You are saying not diagnosis, but yeah, what I need something. Exactly. This is a screening test. This is a screening test. This is a screening test. Or you can say also a prognostic test. This is a screening test, a prognostic test. What is prognostic test? What is difference between screening test and prognostic test, guys? What is difference between screening test and prognostic test? Without using search engine, yeah. Screening test means, I will tell you, let me make you understand, because so many first year people, third year people are also not knowing. Screening test means if the VDRL is positive, it's not that it's 100% positive. First thing, it's not that it's 100% positive. That means he has VDRL, but it's not that he's 100% positive. Prognostic test means status of the disease. Prognostic test means status of the disease. Whether the stage of the disease is getting more towards bad or more towards good. Is it clear? So VDRL, RPR is a prognostic or a screening test. If you don't know this basic, then it's very, very difficult for you to understand a disease. Okay. So this is a non-specific test. Now going to the specific test. It's not that you will mug up and take in the exam. It's not that. We have to treat the patients. How can you read the test then? Prognostic tells me the status of the disease. Status of the disease means if this person has a disease, whether it is going towards bad side, whether he is improving or he is going towards the bad side. Bad. Okay. Specific test. What is specific test? I hope you understand. Now specific means, yeah, it is a final diagnostic test. So there we were using non-specific, non-treponemal antigen. Here I will be using treponemal antigen. Here I will be using treponemal antigen. Here I will be using treponemal antigen. Okay. So what is it called? Yeah. Anyone from the third year? What is it called? It's called TAPPA. What is it called? TAPPA. TPPA. TPPA means Treponema pallidum particulate antigen test. Antigen test. We have others like TPHA. What is TPHA? Treponema pallidum heme agglutination test. Heme agglutination test. We have others like we have TPIA. You don't have to write that. Treponema pallidum immune adherence test. Okay. We have TPI. TPI meant Treponema pallidum immobilization test. Okay, so you don't have to write that, only write these 2, 3. Okay, this is sufficient for you. And we have another, the important one, that is FTABS. FTABS. What is FTABS? Fluorescent treponemal antibody resorption, not resorption, absorption actually. Why it's not writing? Yeah. Fluorescent treponemal antibody absorption test. Absorption test. Understand? So this is FTAABS. Okay. Absorption test. FTAABS absorption test. Fluorescent treponemal antibody absorption test. Okay. Fine. Is it clear, guys? Now, I tell you, a patient has, now I give you a report. Okay. We give you a report now. The report is saying patient has TPPA negative. Patient is TPPA negative and VDRL positive. What is the meaning? You only were saying prognostic, diagnostic. Now let us ask you only. Yeah. TPPA negative, but VDRL positive. I am giving you the also scrolling for you. Okay, see, you can also see. But I am not asking you to teach me microbiology. I am telling you what is the diagnosis. I am not asking you to tell me. You are saying my lines what I taught you. I am saying after teaching all this, I am saying TPPA negative, VDRL positive. Yes, think again. So that means he is not diagnostic. He can't be diagnosed with, he is not having diagnostic. He is showing us something. Yeah, someone has written, he is showing us something. Maybe he is having some infection like that. Okay. So he is showing us what is the, you should not speak like this. He is having some other or something. What is meaning of this? It means it is false positive. You speak like this, I get, I don't know what to say. Say it is false positive. Should not speak like this. Yes, sir, it is false positive because he is not having showing us this TPPA, because TPPA is what? What is TPPA? TPPA is a specific test. He is specific. He is showing specificity. But VDRL is, sorry, TPPA is negative. That is, he is not having specificity. But VDRL is a non-specific test. That is, he can be having any other infection. Clear? Now I tell you, patient has TPPA. Patient has TPPA positive, VDRL positive. What does it mean? Patient has TPPA positive, VDRL positive. VDRL positive. Why it's not writing? Yeah. Okay, first tell me, what will you do with this patient if he has a false positive? What is the treatment? How will you treat this patient? How to treat this patient of TPPA category, TPPA, VDRL, positive, negative patient? This first one, this one. How to treat this? No treatment. No treatment needed. Okay. No treatment needed. Okay. There is no treatment for this. Now tell me this TPPA positive, VDRL positive. What is the meaning? Very nice answer. Very nice answer. That is it's actually an active infection. Very nice answer. Active infection. Active infection. Will you treat this patient or will you tell him go home and sit with your wife? Huh? Will you tell this person to sit with your girlfriend or treat? You will treat. Definitely you will treat. So you will treat this person. Okay. Now I am telling you, the person is having TPPA positive and VDRL negative. What is the meaning? Recovered. Okay, but what is the meaning? Yeah, recovered, but what? Keep writing every word. I want to, get your brain, think about these things, because tomorrow you are going to treat patients. It's important for me to. Uh, 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 friends. You think in a conservative, conservative way. Exactly. That's a beautiful answer. Sharia student, beautiful answer. It's the perfect answer. There is no need to add something. The person has recovered but has memory antibodies. That's a perfect answer. I can write this. Okay, I write this for you for appreciation. He has a sort of memory response. Okay. Now I'm asking you, that's a very nice answer. I'm asking you, we need to think. We are not actually testing someone. We are actually thinking. So how will you treat this patient? If you want to treat, say yes. If you don't want to treat, say no. If you want to treat, yes, then why? If you don't want to treat, then no, why? No, will you tell him to go home? Will you tell this patient to go home? What will you do with this patient? 6, yes, what is? So what is the meaning of this? Actually, I will tell you. Let me make your concept clear, because you haven't read immunology or something. The thing is that even third year people are not able to answer. So let me then speak. See, if for example, I take a boy from you, what is the name of the boy? Let me take some boy, okay? Let me take a boy A. And this boy had syphilis 20 years ago. This boy had sexual transmission 20 years ago. And today, it was the date at that time was 2000, year 2000, 2000, year 2000. Now today in 2020 or 21, he is coming to me and I suddenly check his what? Antibody VDRL. I check his TPPA. It was positive. I say, ah. Then I check his VDRL. Now I don't want to speak right now about VDRL. I want to first make you understand. Then I give example of VDRL positive or negative. No, my dear, how we can be carrier, my dear. Don't speak everything. Everything does not. We don't need everything which we can think. Don't speak everything. See something logical. It is totally out of no context. Whatever you spoke, it has destroyed everything. Okay. So now listen. TPPA positive and VDRL negative. It means even if I come after 100 years, and if you check my antibodies for syphilis, you will get antibody titer. So does this mean I recently had a syphilis infection? So who will tell me? I have to check the VDRL. So I have to check the VDRL, and that will tell me, I will tell him to do VDRL. Okay. So that means a person, even if he takes any medicines, if you want to know whether he had syphilis or not, he will be having the antibodies till his last breath. He will be having antibodies for syphilis till his last breath. Once you check his antibodies, you will say, yeah, you had an infection sometimes back. Now doctors are so much genius, isn't it? They can tell you everything. What you have done, what you have not done, isn't it? You can't hide anything. You can't hide anything. We are taught even whether a person was hit with a pen or with a pencil. The scar will show us whether it was hit with a pencil or pen. That is the forensic medicine what teaches us. Beautiful science, making us literate. Medical science makes us literate. It teaches us, brings us light in our eyes. So see, what you will do with this patient is you will check the VDRL. So according to VDRL, then you will say, yeah, he has an active infection, and then we will proceed in that. So this concept I want to say from an immunological point for you, very rightly written in the very nice standard textbooks. It says this is acting as a serological scar. Do you know scar? Do you know scar? Scar, you have scar marks which don't go. So this is a serological scar. That is, a person can see you anytime. He can check you and then take your lab test, and if you had syphilis, then he will be, yeah, he will know that, yeah, he had a syphilis history. Is it clear? Now, can you understand the VDRL or not? See, we have tried to, if you understand, if you are in line with me, I hope that you will understand. If you are not following me, then it's going to be problematic. See, it is so easy to understand. I hope it is so easy once you understand concepts. Okay, so this is called serological scar. What else can you use as a diagnostic? You can use, now who is 100% sensitive? Serological test, isn't it? Even at secondary syphilis, it will be telling you at 4 weeks it will be positive. Okay, now let me tell you something about how will you know about congenital syphilis? How will you know about congenital syphilis? You will be taking cord blood. You will be taking the cord blood of the baby, and then you will be going for microscopy. This is for congenital. How will you know whether baby had a syphilis or mother? Whether mother had and she transmitted? How will you know? You will check the IgM titer, because IgM is, IgM cannot pass the placenta. IgM cannot cross the placenta. Okay, but IgG crosses the placenta, isn't it? IgG crosses the placenta, isn't it? But IgM does not cross. So IgM will be specific for this neonate. Okay, and you have to check two titers for congenital syphilis. You have to check two titers for congenital syphilis. One is a mother VDRL titer, another is fetal VDRL titer. VDRL titer. Okay, mother VDRL and fetal VDRL titer. Okay, if fetal VDRL is more than this, then you will say it is congenital syphilis. Congenital syphilis. 4 times should be the. So that means if mother's titer is greater than baby's titer, you say maternal syphilis. Baby's titer greater than mother's titer, congenital infection. Is it okay? Fine. Different books will be writing different things. I'm telling you in advance. But I am going to most authentic whatever I have learned. I am going to most authentic. What is the drug of choice? Drug of choice is penicillin. Drug of choice is penicillin. What is the, if the patient is allergic to penicillin, what will you give? Doxycycline. Doxycycline. If patient is allergic to penicillin, then doxycycline. Doxycycline. But if there is neurosyphilis, you have to do desensitization to penicillin. Desensitization to. So in neurosyphilis, neurosyphilis has, in neurosyphilis, we will do desensitization first. We will make the person desensitized to penicillin. That I will be teaching in pharmacology. Okay. Here I need to mention it. Desensitization, because the person is sensitive to penicillin, is that allergic person. Okay. So you have to make him desensitization to penicillin. Then you will give him penicillin. Because he's allergic to penicillin, he will die. Okay. He will die. He will die of anaphylactic shock. Okay. Is it clear, friends? If you want me, I will teach you the treatment of syphilis here only. It is from the pharmacology. But you know, you have to remember them because you haven't read it. I have second year people with me. That is basically a part of my, I don't think that it is appropriate to talk here. about that. Penicillin G, 2.4 million units. But if you want, I can. So how many yes we have? Okay, right. Yes, right. Today also you have to write. Tomorrow you have to write. So write it today only. Let me teach you the treatment. Okay. Now let me tell you the treatment of syphilis in detail. About treatment of syphilis, if you have a primary syphilis, a secondary syphilis, or early latent. What guys? Early latent. That is latent phase of early phase of latent. You will be giving benzathine penicillin, G, benzathine penicillin G, 2.4 million units. 2.4 million units IM once. Pharmacology is so beautiful. That is, you only have to give one shot. Okay, or jab, whatever you say. Latent or uncertain duration, we give benzathine penicillin same, 2.4 million units same, but I am weekly for 3 weeks. If you have a tertiary syphilis, but without there is no neurosyphilis. There is no neurosyphilis. If a neuro, what I am writing, neurophysiology, neurosyphilis. Then we will be giving him benzathine penicillin G. 2.4 million units. I have taught them in pharmacology, but they don't remember. Okay, I am weekly for 3 months. Weekly for not 3 months, it's 3 weeks. Sorry, weekly for 3 weeks. Weekly for 3 weeks. If the patient has now neurosyphilis, oh my god, then it's going to be neurosyphilis is neuro, man. Neurosyphilis, neuro, we are concerned about always. Once I listen to the word neuro, I feel like, oh, neuro. So we give aqueous penicillin G, 18 to 24 million units, IV daily. IV daily. I am saying tertiary without guys, without is written like this. How to show you? Without neurosyphilis. Because tertiary will be showing sometimes features with this. Tertiary is showing neurosyphilis, na? Tertiary syphilis is showing features of neurosyphilis. I taught you. Isn't it? Or you have forgot? Meningitis, everything I taught you. So why are you asking that question again? Neurosyphilis now. If it is perfect neurosyphilis, so what will giving? Aqueous penicillin G, 18 to 24 million units IV daily. Every 3 to 4 hours. Or you can give it as continuous infusion. Continuous infusion for 10 to 14 days. 10 to 14 days. This is, I have integrated pharmacology with this. Okay. This is not a microbiology part, but yeah, pharmacology, they may ask you the question, which penicillin we are giving for this, which penicillin, how much dosage, 2.4 million units, 2.4 million units. This is also 2.4 million units. Okay, we have finished with the syphilis part of the spirochetes. I hope you have enjoyed this topic. Whatever we have taught you, it is all about integration. I have tried to give medicine also. So hope you enjoyed it. See you all tomorrow. Take care. Stay safe in Corona. Bye-bye.